Okay, so this is the second part of Chapter 4, and I wanted to mention a few things about interpersonal relationships. The book gives you several suggestions for how to build effective client aid relationships, and these are what I would say are nice suggestions for any kind of collegial relationship that you would have in the workplace. They talk about avoiding changing the subject. You want to make sure to fully acknowledge, appreciate, and respond to questions that clients have. Don't ignore clients, of course, and their requests, and don't talk down to a client as if they are incapacitated, unintelligent, or somehow, lesser. Don't. That's just an inappropriate thing to do, and it leads me to want to mention people first language, which is I'm going to remind you to again, please read Appendix I and J carefully and fully. They're both excellent, and I'm going to try to pull up. This is from Appendix I, and this is an article about people first language. So it's really getting at talking about people first instead of their disability. And they give a lot of wonderful suggestions of examples of people first language. So if we look at this first one here, they recommend that we do say people with disabilities instead of the handicapped or the disabled. They recommend that we say things like he has a cognitive disability instead of he's mentally retarded. She has autism instead of she's autistic. So what they're getting at is a movement away from labeling, away from calling a person their condition or their disability, and instead they're people first, and they happen to have a challenge. They happen to have an issue that affects their ability to learn or something, and they're working on that. So trying to focus on these types of strengths and what we all have in common, which is that we're all people first. Therefore, I'd like to then turn to Appendix J, and let me see if I can get this one up. But this one is about disability etiquette, and they give some excellent examples in this document of how to interact with people that have disabilities. And this includes working with someone who's in a wheelchair, as well as people who are deaf or may have their speech affected by a condition or a disability. So I want you to read through these two documents because they're just great in their suggestions for how to work with those types of clients and how to serve them in a way that's respectful and effective. So please remember to look at those. Let me go over a few more items here. These are things that I think are really critical that you understand. The first here is the difference between objective information and subjective information. So, we talked about verbal and nonverbal last time. Now we're moving on to objective and subjective. So, data that's objective is information that can be collected using any of your senses, something that you hear, something that you see, something that you smell or touch. Subjective information, on the other hand, would be something that can't be observed but is typically based on something the person reports. So, for example, a client could say, I have a headache. That I can't really see their headache. I might be able to see expressions on their face of discomfort. I might be able to observe increased pulse rate and increased blood pressure, which is also consistent with pain. Those two things increase when we're in pain. So what we do when we collect subjective and objective information is we look for kind of a constellation of factors that lead us to a diagnosis or what we're looking for with the client. So I want you to have those very clear in your mind, what the difference is there between subjective and objective. Pertinent is something that's significant or useful. Often when we're writing in the chart or we're giving a verbal or oral report as we're signing off maybe to another aide or to a nurse, we want to let them know what's going on with the client. We want to focus on what is really pertinent information, what is significant, not a lot of extra details that they don't really need, but things that are critical to the client's care. So documentation is very, very important, and it helps us to provide appropriate care for clients, describe how the visit went, describe client improvement, client deterioration, things like that. Basically, just the status of what's happening with the client, and it needs to be clear for a lot of reasons. Some of them are that it guarantees complete communication with with the healthcare team. It provides a legal record of treatment. And it protects the aide and the employer, so you're assured if it's documented, it was completed. We have a saying that we used to say: if it isn't if you didn't document it, you didn't do it. So, you may have taken the client's vital signs and written them on a scrap of paper, but if you didn't transfer them into the client's chart, there's no proof that it actually happened. And it again provides an up-to-date record of what's happening with the client's status and care. These days, I came up through the nursing system with paper charts, and now there's a big movement to electronic charting. So I wouldn't be surprised if home health aides and personal care attendants are also going to make that move to an electronic system, which really gives you the client status and update, in real time. I could imagine in today's networked world, virtual world, that you could be at a client's house, working on the laptop and updating things, and there could be a nurse manager or someone at the agency who's able to see what's happening at several locations at the same time just by reading the data that's being entered. I could see that in the future if it isn't already happening. So again, they provide us with visit records. These include progress notes, clinical notes, updates, all kinds of things. The other type of record that might occur is an incident report. This is something that gets generated when there is an accident or a significant event that occurs during a visit. So an example would be like a fall. That's a significant incident. If the one that comes to my mind as a nurse, the incident reports that I'm familiar with are if you're stuck by a needle, if you accidentally stick yourself, or I used to work in trauma, so if somebody actually accidentally pokes someone with a needle, during the chaos of an emergency, that has to get reported and dealt with. So those are two different types of documents that you might be familiar with. Let's see. Again, I've really tried to emphasize this idea that if it isn't documented, there's no legal record that it was done. It's important to realize that medical charts are confidential. They belong to the patient and the agency. And again, you want to review the basics of charting, and this is also something you'll develop in practice. And also, you'll be able to practice and develop methods for giving oral report. And abbreviations, I want you to review the list of abbreviations that they have in this chapter, just so you can start building your vocabulary of medical terminology. I made these definitions again because I really want to emphasize you've got to know the difference between subjective and objective. Here's a little graphic that helps you focus on what is objective. Something that you can smell, maybe the client's breath, that can often communicate it could communicate infection, it could communicate, if they have fruity breath, they might have a very high glucose level in their blood. The changes in appearance, if a client's losing weight, if a client appears pale. Hearing the client's tone and breathing, you could tell if they're getting more disoriented, even by the words they're choosing. And their breath, of course, if they're breathing more quickly or more shallowly, that can mean all kinds of things. Touch, their skin could feel clammy or hot or cool. You can also check for hydration. And then pulse, of course, is something you can feel. Okay, so let's talk about, again, getting back to the importance of documentation. We've got, you really need to get in the habit of writing your notes either during the visit. I see a lot of clinicians doing that lately, typing into the computer while they're in the room with the client, or immediately after your visit. The longer you wait to document something, the more likely it is you're going to forget something. Sometimes you can prepare your documentation. Sometimes when I would go into clients' rooms, I would make notes on just a piece of scrap paper, and then when I transferred that to the client chart, I would do it in a way that was more orderly and made sense in terms of what I wanted to communicate. You want to write neatly, of course. With the electronic age, you'll probably be typing. Correct errors appropriately. There's a page in your textbook I want you to look at, page 39. Of course, sign your initial things and sign where appropriate. And again, incidents, like I mentioned earlier, those would be things like falls, any kind of damage, inappropriate things. Unfortunately, that does happen in sexual advances. You know, clients could be disoriented or they could just be behaving inappropriately, so you'll want to make sure that is documented and, of course, reported to the supervisor. Any kind of situation that's unsafe, any kind of injury, blood or body fluid exposure, as I mentioned with the needle sticks. You know, it's a rare occurrence, but when it does happen, it's an incident that has to be reported. They also talk about ways to organize yourself when you're giving report over the phone. You might have to make a call to a supervisor or a call to a nurse or a doctor, especially if you have some data that they're going to need to respond to, for example, an elevated temperature or something that might need attention. So you'll want to be able to identify yourself, the client, leave the information if it's going to be a message, thank the person, and be clear and direct and to the point. This chapter also talks about cultural diversity, and we could have a whole semester course on this, but you do want to be clear about some definitions. So be comfortable with the definition of cultural diversity, the definition of bias, and of course culture. Sets of behaviors that are learned within a group of people, often people that we live with. It could be associated with lifestyle, custom, religion, beliefs, those types of things. All of that contributes to a culture. Another term I want you to be comfortable with from this chapter is combative. Unfortunately, with a lot of elderly clients and clients that are sometimes disoriented, either secondary to their physical condition or secondary to medication, can sometimes be combative, which means they could be violent or hostile, and you need to be clear about how you're going to cope with that. Sometimes you need to get extra assistance, extra caregivers involved, especially if a client is unpredictable. So ways of coping with somebody that suddenly gets combative. You want to get out of the way if they're trying to swing at you. Get away. If the client can be left alone, you want to make sure that you move away to a safe area and that you call for help or call your supervisor, let them know what's happening, and then take direction. You never want to get back into a verbal exchange with somebody who's attacking you verbally, and you want to do whatever you can to de-escalate the situation and get to a safe space and don't provoke the client. So read through those types of things and make sure that you have a sense of how one might respond. Other things that are inappropriate behavior would be clients that ask you for favors, request to see you outside of a typical work setting, give you gifts, ask to borrow money. All these types of things are red flags. If a client was to make a sexual advance or ask you to perform a task that was outside the care plan, these are all things that would need to be reported to the supervisor and let them know that that's not a part of your job and that's not consistent with the care plan and that that's not something you're going to do. So what else? Other ways of handling inappropriate behavior can be just a calm approach. Try to address the behavior. Try to give information accurately and honestly and appropriately. Gifts, it's always a a tough situation when somebody wants to thank you and they want to give you a gift. Um, I often have to explain, I can't accept it, unfortunately, in the work setting, and I apologize